So we're getting ready for a mailbag episode. And Dr. Cooper, you're our resident data analyst for Fat Science in terms of tracking where our listeners are. And I was shocked to find out that outside of Seattle, the number one city where people listen to the podcast is what?
London. Yeah, it is. Even above other cities in the U.S. It's Seattle, then London. So I'm so excited about having so many listeners from London.
That's cool. And we do have a letter from London from a healthcare provider, which I find fascinating. We're starting to get more and more correspondence from healthcare professionals, aren't we?
Yeah, we get quite a bit, actually, from all kinds of healthcare related fields. And so happy to talk to people in the healthcare field.
So, Andrea, can you do a British accent?
Not really. I mean, I have British relatives, and mostly they make fun of me. They always make me say coffee, basket, stuff like that. They make fun of me. I don't make fun of them very much because
I wish I had
it's not nice. I can kind of do it, but it would be too embarrassing here.
Yeah,
but I let them all make fun of me.
All right, let's get to the mailbag. Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. Good to see you two.
Hello.
These are some of my favorite episodes, the mailbag episodes. We're getting letters from people all over the world. I guess I'm dating myself when I say letters. We're getting emails.
I like to say letters.
Letters from all over the world. And let's start out with our first one from the United Kingdom. This is from Anu. And she says, I really enjoy listening to your podcast, and I'm learning something new every day. I'm a general practitioner in the UK, and I put my hands up and admit that I have on occasion advised patients to go on calorie-restricted diets and to exercise more. I've been doing it myself, and despite only eating in a 2-hour window, I continue to gain weight. Now I know why. I'm keen to learn more about metabolic health, a post-grad qualification maybe. Do you have any recommendations on courses in the UK? I've looked at a few, but as soon as I see the module on low-carb, low-fat diets, I don't bother. Also, in my case, my BMI is 26, been dieting for 10 years or so. My most recent HbA1c and lipid profiles have been normal. Here's a question. Would eating whole foods at regular intervals reverse my metabolic dysfunction, or is going on GLP-1, GIP drugs inevitable? Many thanks, Anu. So, Anu, thanks so much from the UK.
Oh, that's a great question. Hi, Anu. Thank you so much for this question. Well, it is a little bit concerning because if, you've done this for a long time, the calorie restriction and the fasting and the fasting windows being so long and all of that and the exercise that's underfueled, things could be quite unbalanced metabolically. And so it's hard to know what the best solution will be. But definitely eating whole foods regularly throughout the day is a good strategy. The problem is if your metabolic situation is in a state of fear and panic that you're starving and you're gaining weight doing what you're doing, it can take a long time of eating regularly like that to restore the trust in the system. So I do think you most likely some kind of pharmacology would be helpful. I'm not saying it would necessarily be a GLP-1 type med, but something to help prevent those famine signals from being so amplified, because it takes a long time for them to come down. And so I would hate to see you, as you're making this dietary adjustment, it can get very unstable at the metabolism because it's, one foot's trying to trust and the other foot's holding it back. And also glucose and insulin levels can become very erratic and unstable as you're making those transitions. So the ideal thing would be to be medically monitored as you're doing it, to measure some of your lab work, the glucose and insulin before and after eating, to work with a dietitian on maybe gradual small steps. Since if you're not being monitored closely enough, I would do it gradually, the shift. And, you got to hope for the best. But I would like to say it'll all be fine, but I've seen patients like this, and I like to have like a strong metabolic evaluation and a treatment approach to it to really figure out what's going on, and to stay on top of things so that there isn't that instability that people have to experience. So I can't really prescribe any medications on the podcast, of course, but I can think of some that I find are helpful, for this type of thing that you could run by your provider. Maybe you could send another email for more information, and we could maybe go back and forth a bit on it. But another thing to do would be to make sure you do a body composition test to verify that there's not any visceral fat. So ideally with the DEXA scan machine, which will show how much, it gives it a sense of the visceral fat component. Because remember, we talk about weight cycling in people that are close to normal weight, and they can actually end up putting a lot of weight in the organs, and fat in the organs. And so you want to make sure that's not the case. And we also want to know, why did you start doing this in the first place? Was there already some kind of underlying metabolic problem that you were trying to address through this change in your lifestyle? And is there a diagnosis for what that was? Did you have any baseline glucose elevations, insulin elevations? Could you potentially have anything like something called lipodystrophy, which affects like the body's ability to manufacture leptin normally? And sometimes you'll see that in people that are close to like a normal, quote, BMI. So it's very complicated. I wish it was more simple and straightforward. And the other part of your question about a training course, believe it or not, people who are out there waiting for my training course to get updated, I keep saying it's almost there, and my companion manual is almost revised as well. So I know people have been patient that are wanting to sign on for that virtual training course, and that would be something that we're trying to put the time of it for people who are over in the UK that could join at a reasonable time, and it will be a virtual course. So stay tuned, and we'll announce it on the podcast when it's ready for people to sign up.
All right. Anu, thank you so much.
Okay. Dr. Cooper, Mark, and Andrea, thank you for all you're doing to shed light on obesity treatment. The podcast is so helpful to me. I have a question. Maybe it's for a mailbag episode. Well, yes, it is. I'm currently considering bariatric surgery because my insurance covers that. I'd like to know before I do the surgery if there are any tests that might identify the root cause of my obesity. If my root cause will not be rectified by having the surgery, I'd like to know that. Of course, I've tried to find a doctor to help me with that question, but I'm not having any luck. Perhaps if I knew what test to ask for, I might be able to get someone to help me. Thanks. Jen in Pennsylvania. Interesting. I had bariatric surgery.
Yeah, you did.
I did, but I had a lot of tests.
Mm-hmm.
I don't remember. It was a while ago, probably like 5 years ago, I guess. But I did have a lot of tests. I don't know if the ones that I had for the bariatric surgery did figure out the root of my obesity. I think those were more with you, Dr. Cooper.
Well, yeah. One reason why we were pushing you toward the bariatric surgery was a couple of things. You had high famine signals, including ghrelin.
Right.
Ghrelin is a hunger hormone produced by the stomach. And your response to the pharmacology was...
It was good, but it was panning. It was plateauing out. I had lost probably about 80 pounds at that point, but it was stopping.
Yeah, and we had some limitations because you reacted to one medication that was helpful that we couldn't use. And so we were kind of thinking, so that's in my mind, one of the indications for bariatric surgery is just pharmacology is just not strong enough and it's not effective enough, or it can't be tolerated. Some people can't tolerate the pharmacology, or they've got a long way to go and they've got a pressing medical issue like diabetes uncontrolled or something like that. So those are kind of some of the things. But bariatric surgery is a great tool, so I wouldn't shy away from it. But some tests that can be very helpful that I found in my own practice in patients who have really a lot of insulin resistance. Usually they do very well with bariatric surgery. It's usually very effective. And how do you know if you have insulin resistance? It's measuring the insulin levels. And so that's insulin fasting along with your glucose. And there is something, just a real quick, easy formula called the GIR, glucose insulin ratio, which you take the glucose, divide by the insulin. And if it's below 7 or below, that would kind of favor that you've got insulin resistance. Some people say if the insulin fasting is above 12, but that could be mild insulin resistance and not too much of an issue. So the ratio is a good thing to look at. There's a more complex formula called HOMA-IR that can be used too. But in any case, the fasting insulin and glucose, and then ideally after you eat, looking at your insulin and glucose after eating too, gives you a sense of that. But if you're a person that has very high fasting insulin, very high insulin after eating, and the ratios we want to see after eating are the opposite, the insulin divided by the glucose, and we want that under 50%. So if you're off balance with those two with excess insulin, then that's a good, just easy nitty-gritty indicator that you probably will be a good responder. Because what they show with bariatric surgery, and I do favor the VSG just because it doesn't affect your absorption at all of any nutrients. A lot of bariatric surgeons kind of think I'm silly for that because they recommend some of the newer procedures that have less impact on nutrient absorption, but they do involve a bypass where they bypass part of your gut. So they have that potential to affect your nutrient absorption. But they try to reassure me that they won't cause an issue and they're more effective, supposedly. But I still shy away from them just from my experience with some patients that have had bad results from the malabsorptive procedures like the gastric bypass. I mean, it's a very effective procedure, but what I'm getting at is if you're somebody that could respond to the VSG, which is a much less invasive, that might be a good choice. But that's between you and your doctor or your surgeon. But the bariatric surgery, what they found is within 4 days of the surgery, the insulin resistance is markedly reduced, if not eliminated, which is like a miracle. So having the surgery is like taking a huge dose of medicine. And so I think that if you can measure the insulin levels, it's great. If you can measure a ghrelin level, that's great too, because if you have high ghrelin, then the VSG procedure removes the lower part of the stomach, which is the main producer of ghrelin in our body. So that also can be beneficial. So there's not like a magic question about it, but I think having those baseline tests gives you a better sense.
Yeah. I mean, for me, it worked a little in the beginning and it helped, but I did still go back on medication.
Yeah, in your case, you had
I'm very stubborn and very
you
tough.
In your case, you had like a slow initial response after the surgery, but that was after having no response. So it
Right.
helped get things going.
It did help. I still think it was positive.
Right. And then once after the surgery, you kind of start adding back medication, which you did. The medication has more impact because of
Yes.
having the surgery. And so then so it's like again, we talk about synergy a lot of times,
Yeah.
synergistic impact. So it's like the surgery alone, the medication alone, but you put the two together is often very effective for people that are in that kind of resistant category.
Yeah. But it was not it wasn't like, don't expect miracles. I always say to everybody who's thinking about it, don't expect a miracle.
Yeah, and there are small percent of people who gain back all the weight and more after surgery.
Right.
It's not common, but I have had them in my practice.
Yes.
So
I've known people.
Yeah. Well, Jen, thank you for that question. We're going to stay on the topic. We've talked about plateaus on the podcast in the past. This is a question that is dealing with plateaus for someone who's had bariatric surgery. So Emily sent us an email. Hello, Fat Science team. I'd love to suggest a podcast topic. For patients who started with a very high BMI, like 60, had bariatric surgery, lap band revised to DS. I have to ask, what's DS, Dr. Cooper?
the duodenal switch, which It's a combination surgery of the VSG type procedure where part of the stomach's removed, but then also there's a bypass.
Oh, okay. So it was revised to a DS. Now, 20 years later, she's dealing with menopause and aging. Weight loss is slow, even on Zepbound. These patients often have persistent metabolic resistance due to longstanding obesity, issues like leptin resistance, insulin resistance, and impaired satiety signaling. So, Dr. Cooper, 20 years in, she's kind of struggling with the weight now. So I'm guessing this is not an uncommon thing, or is it?
It's not common, but I have patients in my practice. She reminds me of some of my most difficult patients. It is not common, fortunately, for the masses, but it is unfortunate for Emily that she's dealing with this.
Yeah. So what's your advice? I mean, what can she do?
Well, the thing is that the surgery, the duodenal switch surgery, was thought, especially 20 years ago, to be the most effective. And so you're doing some kind of more radical, it's not radical, but, more extreme surgery. And you're on, sounds like on the Zepbound, I don't know what dose it is, but which is supposed to be the most effective of the meds that we have, and still resistant, And so obviously there's like huge genetic component to this. And so one thing I would advise, if possible, just for curiosity, is to look into, there's a program which is like uncovering rare obesity, and it's through Prevention Genetics. Rhythm Pharmaceuticals offers genetic testing for people who are eligible at no cost to look for what's called monogenic obesity in the brain pathway, the melanocortin pathway that we always talk about. The central metabolic pathway is called the melanocortin pathway. And they measure about 90 different potential monogenic mutations there to see if something in there is off, and maybe it's not, but it might be. In these kind of more severe cases, it's kind of good to look at that just to kind of give a little bit more insight in case something does show up on that. So certain things that would show up on that would be leptin receptor mutations, something called a POMC deficiency. There's all kinds of things that could show up, including a melanocortin 4 receptor deficiency. So I would try to push for that. You can actually go on to, I don't know, it used to be called the Tempo Tracing the Melanocortin Pathway in Obesity program. But I think I'll post it in the show notes, the link, and you can go on as just an individual to sign up, and they'll send you a kit to do the testing. You have to fill out some questionnaires and stuff. But there is certain eligibility criteria. Having had surgery in pharmacology is not disqualifying at all. But anyway, so aside from that, you want to get to the root of what is really going on here. And one of the things we see most often in patients like this is a problem with hypoglycemia and after eating, where the blood sugar and the insulin are off balance. And if you don't correct that, none of these medications usually will have a whole lot of effect. So I would push for a test. It's called a mixed meal tolerance test with glucose and insulin levels. And that's one where you're not drinking the glucose drink. You're eating a regular meal. You do the fasting, glucose and insulin, consume the meal, then 30, 60, 90 minutes after, check those glucose and insulin levels and, see if there's some dysfunction going on there. And if so, it is treatable. So, but again, it's complex kind of on the podcast explaining all this. But I wouldn't give up hope. I would try to say that you haven't really figured out what was wrong actually yet. What is causing this. And so I wouldn't focus so much on the weight loss yet. I would more focus on what is driving the problem and what is happening and the potential cause of this.
Yeah. Emily, thank you so much for listening and for a really good question. All right, Andrea?
Okay, here we go. This is from Jennifer. Hello, Fat Science team. I'm 72 and have been on tirzepatide, it's so hard to say that, for 33 weeks with great appetite suppression, but I've only lost 15 pounds. I take prednisone, 5 milligrams a day, for chronic pain from scoliosis and can't exercise much, though I do PT and walk daily. When I lowered my prednisone dose before starting GLP-1, I lost 25 pounds easily, but can't reduce it further. Now, at 174 pounds, 5'3", I'm not diabetic, my labs are good, and I eat a healthy, high-protein diet, 1,100 to 1,500 calories a day. Is prednisone why my weight loss is slow? Any advice? Jennifer in Boulder, Colorado.
Well, hi, Jennifer. Another great question. A couple things you said have a little bit of red flags to find out what's going on with your lean mass. Remember, lean mass is everything but body fat, but focusing more on like your muscle mass, because your calorie intake sounds like it could be kind of low, actually. And you aren't able to exercise very much. You're doing the PT, it sounds like. And you do the PT exercise and the walking, but you were saying that you have chronic pain, so that might be affecting the amount that you can exercise too. So again, I would actually recommend body composition testing to find out what your current status is in terms of your lean mass, and making sure that your lean mass amount is enough, because you don't want to just focus on the scale number, because we don't want it to go down. If you're losing muscle mass, we don't want to lose any more muscle mass. So that would be one thing. So instead of talking about like weight loss goals, we want to look at the body composition and the body fat versus the lean mass. And because at 5'3", most likely that is an elevated weight, of 174. That's not normally going to be in a quote normal weight range. So I'm sure that you probably do have some more body fat that you could lose, but you probably also might be dealing with a little bit of lean mass loss. So that's something that I'd want to monitor closer. But then the prednisone definitely hampers metabolic function. And the longer you're on it, the more it does hamper that. But I would almost try, trying to eat more first before worrying so much about like raising the dose of the medicine, the Zepbound, or changing your prednisone, which obviously you can't change. But maybe trying to do an experiment where you kind of boost up your fueling. You said you eat a high protein diet. That's great, but we need also carbs and fats and all that. A balanced diet that's a little higher calories, because I think that might be just a little too low. And then trying to see if through your physical therapist, you might be able to do more strength training, even though, you've got the PT exercises, but can they keep pushing that somehow, make modifications to help you build and retain more lean mass? Check your body composition. And then if you feel like you're fueling well, you could try increasing the Zepbound most likely, because it does have to fight the effects of the prednisone. And so the prednisone kind of hampers our metabolism, and the Zepbound helps undo some of the damage that the prednisone is doing. But I think also looking at insulin levels would be helpful here.
Okay. Jennifer in Colorado, thank you so much for that. We're going to stay in Colorado. And here's an email from Michelle. Hello, Fat Science team. Since starting Zepbound, a GLP-1 in January, I have had amazing results. Weight loss, improved PCOS, and my fatty liver is now undetectable. However, my recent labs show very high ALT and AST levels, which is new for me. The only change has been starting Zepbound. So my questions for Dr. Cooper: have you seen GLP-1 meds like Zepbound cause this? If so, what are the next steps? If not the medication, what else could be causing this? And also, can you recommend somebody familiar with GLP-1s in Colorado? Her current GI just took her off Zepbound. So thanks so much for your help. Feel free to share this on the show. Michelle, that's a really good question. You've seen this before, haven't you, Dr. Cooper?
Well, I have seen it, but not often to this degree that Michelle is describing. She actually provided the numbers for her lab results, which are like off the charts. And
this is a liver test, yeah?
It is, yeah. These are liver tests, ALT and AST. And so I have a couple questions about it. Jennifer said, Michelle. Sorry, yeah. Michelle. Michelle, you said that the fatty liver is now undetected. So I'm curious, how was that measured? Was that an ultrasound, one of those fiber scans? because the number, it's normal when your weight either goes down or up. It's totally normal to see those liver enzymes fluctuate. So when we see them fluctuate a little bit, we look at the weight trends and we're like, oh yeah, it's like weight related fluctuation, either up or down. But the amount that you listed is beyond what it should do for that. So you'd want to get to the root of what caused that. And I don't really blame your doctor for stopping the Zepbound, because even though it's not a reported thing, that occurs, the timing made it suspicious. And without knowing what that's doing, if that represents some kind of irritation in the liver, you'd want to, as a precaution, stop that. And then remeasure when you're off of it and see if it improves. And if it doesn't, then you can say, okay, it's not that. What is it? But there's all kinds of things that you measure when you see that, which would be like hepatitis profiles. There is something called autoimmune hepatitis, and that should be part of the workup to rule that out. Liver ultrasounds and things like that. So I think your doctor's starting out the right way. And then you did say that your ultrasounds and hepatitis tests are normal. So you already did that. And then I would just make sure that you've also considered that autoimmune hepatitis as a potential possibility as well. And if it really was some kind of, it also could be a supplement or an over-the-counter medicine like Advil, ibuprofen can do that. And so I'd look at everything that you were doing, because it is very unusual and it's not reported that I've seen for Zepbound reaction, which doesn't mean it wasn't the Zepbound, but in your case, because you can have these. But I would also maybe report it to Lilly, have your doctor report it to them, and then they'll put it into their data bank and provide more information of whether any of their aftermarket reports are showing anything there. And then once it's in their data bank, the FDA also has access to that. And so it's just part of a potential adverse reaction reporting system. And so I would do all those things and hope that it's not the Zepbound, and it was just sort of some minor thing that your liver got irritated from something. Also certain viruses can affect the liver also that are not just hepatitis. So sorry, I don't have a more clear answer.
Oh, that's a really good response. And Dr. Cooper, when the liver enzyme numbers come back like that, is it an indication that the liver is struggling, or that it's having to deal with too much toxins of some kind?
Yeah, I mean, it's the liver cells reacting that they're struggling or they're strained or they're inflamed. Mm-hmm. So by something. So, alcohol can be a cause. And so can the other thing would be, I mean, it's not in this case because there was an ultrasound, but say you had a gallstone that blocked the bile ducts and then the bile started like backing up through into the liver, that could cause it, that irritation. But medications are often a cause, but usually not Zepbound.
Okay. Michelle, thank you so much for listening and for a great question. Andrea.
Hello, Fat Science team. Thanks to your show, I started Mounjaro last year for type 2 diabetes and obesity, and have lost 68 pounds. Wow. I feel better than I have in decades. My primary care physician prescribes my medication and checks my A1C, weight, blood pressure, and basic labs, but I don't get extensive metabolic testing, and insurance likely wouldn't cover it. My question, for those of us who only get basic monitoring, how do we know if we're candidates to stop GLP-1 meds or if we need to stay on them long term? My numbers are now normal, but I assume that's because of the medication. Just as I stay on blood pressure and metformin meds to keep things controlled. The ADA 2025 guidelines say even weight loss meds should be continued to maintain benefits. I'm grateful for these meds and your podcast, but I worry about the lack of guidance on when or if it's safe to stop them, especially without more advanced testing. Looking forward to more research on long-term maintenance. Thank you, Marlena.
Aw, that's such a nice...
That's so nice. She said that she started because of us, which that's kind of interesting. But 68 pounds in a year? Whoa, whoa, whoa.
Well, that's the thing. We don't really know what the starting weight and things like that were.
Right.
But we did do an episode on how do you know, like when you can stop and things.
Right.
So we'll put that link to in the show notes too for just a reference. But in general, I'm so glad the ADA guidelines said that people should stay on these meds, as part of maintenance,
Yeah.
because we need to think that way. Because if we're dealing with this multi-metabolic hormonal problem that causes obesity, you would think that it needs to be treated because it's a medical issue.
Right.
And so, but there are cases where some people can taper off the medication or at least go to lower doses. And that is very common, actually. And so, I mean, going to lower doses is very common. Tapering off altogether is not as common.
Probably not.
But it can happen in some rare cases. But, I think that one of the things is you want to be sure that you're eating normally, because sometimes when it's time to taper, you'll start experiencing a little bit more side effects from the medicine. It'll feel too strong. So I've noticed this with my patients where they were doing fine, and then they start having like side effects from the medicine, feeling too full, feeling nauseous. And when we looked at everything, we realized that the dose was too strong for where their system was at the time, at this endpoint where everything is lining up, where we didn't really need that strong of a dose. And so reducing the dose and just a little bit, and then monitoring over the next 3-4 months and seeing how things go gives you a little bit of input on whether, that seems like a good direction. If everything stays stable and you're feeling a little bit better, then you can stay at that, for a while, and then maybe try to reduce it again, maybe 6 months later, just a little bit. Usually when we reduce these doses in patients, it's over a 2-year period at least. So, from a middle to upper dose, it's going to be a multi-year process.
Yeah,
of
she's
tapering.
only been on 1 year.
Oh, yeah, and you've only been on it for 1 year. So I think it's tough, but it is hard, without lab monitoring, but you can still pretty much figure it out, because you want to keep a level of stability at least 6 to 12 months where everything's stable before you try to taper things. I mean, you don't need to taper unless you're having these side effects that are indicating that the dose is too
Yeah,
strong.
she's not.
Yeah.
Okay, Merlina, thank you so much.
Wow,
Well,
68 pounds in 1 year.
That's a
Whoa.
lot, yeah.
That's a lot.
All right, our final letter today is from Susan in Australia. Hello, Fat Science team. Thank you for your podcast. I've learned so much while starting GLP-1 meds myself. Your focus on the science behind metabolism has helped me avoid undereating and better understand why diets don't work. I'm now working with my doc to get baseline tests as you've recommended. But I'd love to hear more about metabolism during perimenopause and menopause. A lot of women I know are struggling with weight changes during this time, even if they never had issues before, and feel frustrated when diet and exercise don't work as expected. Oh, there's that word again,
There's
diet.
that word.
There's a lot of confusion and distress. Dr. Cooper once mentioned that menopausal hormone therapy, MHT, can affect metabolism. For many of us, it's essential, though, for functioning, but we worry about how it interacts with metabolism and weight. Is there a way to balance MHT and metabolic health without stopping hormone replacement therapy? Can you dedicate an episode? I think we've done some on perimenopause before, but Dr. Cooper, explain. I don't know what that therapy is or what it does. But it's a great question, isn't it, about how that can interfere
Really
with
good.
metabolism?
Well, Susan, thank you so much for a great question from Australia. Years ago, we had a lot of research on hormone replacement therapy for women, and it had a lot of negative press. I've been in practice now for multi-decades, and first it was the greatest thing, then it was the worst thing, then it was the greatest thing. And so now we're seeing that some of the negative reports were not very accurate. So it's falling into more favor now to replace hormones, especially for women that go through menopause at kind of a younger age. But there is a little bit of concern metabolically with hormone therapy. There's some pluses and minuses. So estrogen has some very beneficial impact metabolically, Because for women, there's the period of perimenopause where the hormones are weakening, and that's a fluctuating state of estrogen levels that goes on for sometimes up to 2 years. So there'll be symptoms related to menopause, hot flashes, joint pain, insomnia, that come and go for a couple of years. And then after a year of not having a menstrual cycle, that's now considered menopause, where the hormones are pretty much just stagnant and stable, and they're not active. And so the question is, do you replace those with estrogen and progesterone, are the two hormones that are part of the menopausal hormone therapy? And for women who still have their uterus, you can't just take estrogen by itself without a potential risk of developing endometrial cancer. Endometrium is the lining of the uterus. And so it's always recommended that you pair the estrogen with progesterone. If you don't have a uterus, that's not really as much of a concern. So you can take estrogen monotherapy, meaning just estrogen, without worrying about that. So estrogen has positive impacts on metabolism because it helps your brain see your leptin. Remember how important leptin is? It's that hormone from the body fat that reassures the brain that you weigh enough. And so estrogen enhances that leptin signaling. And that's why some people, when they start going through menopause that have already a low leptin level, experience more weight gain because, they already had a weak leptin level, and now their estrogen's dropping, which is causing further weakness of the leptin signaling. But for a lot of women who don't have that problem, they don't experience weight gain, I've noticed. But then, so if you add the estrogen back in, it could help potentially metabolically and strengthen your metabolism. But the problem is that progesterone has negative metabolic side effects in most of the different forms that you take it in. And so it can increase insulin resistance, increase glucose levels, increase body weight. And so that's a problem. If you have to do the combination therapy, then you're kind of navigating how little progesterone can we use so that we're protected against endometrial cancer risk, but we don't want to get the metabolic side effects. Because in some women, progesterone has a similar effect on their metabolism as steroids do, like prednisone. But the good news is there are some formulations of progesterone that have less of that impact. And so if you're on hormone therapy, you want to look for the progesterone to come from what's called micronized progesterone, which here in the U.S. is Prometrium, but I think around the world it should be known as micronized progesterone. That particular form is the least metabolically unfriendly. And it is in a pill. So the patches typically don't have micronized. And the IUDs that are becoming popular to put an IUD, such as what we call it here at Mirena, or progesterone-based IUD, in combination with a patch of estrogen, that also, it could be metabolically detrimental compared to the micronized progesterone. So I guess the ideal would be the estrogen patch, which carries low risk of problems with health, adverse health outcomes. So the estrogen patch plus the micronized progesterone pill would be the most metabolically friendly way to address it. So yes, there is a way to work around the negative potential impact of some of the progesterone formulations.
Wow. Dr. Cooper, I just had one thought. How do you remember all that stuff? On a good day, if I find my wallet in my shoes, it's a really good day. And here you are talking about micronized progesterone.
It's just like you would, it would be the same thing if I had to go on like how you used to go on to the news as a news anchor and do that off the top of your head.
Oh,
I could never do that. So
this has been super fun. Man, we've learned a lot this episode.
We did a lot of topics.
yeah.
And we
these are
should
great
say
questions.
this, in a couple of months, we're going to be celebrating our 100th episode of Fat Science. And I love the fact that so many of you are listening from all over the world. Our plan is, in the next 2 months, we're going to plan a Fat Science live episode. It's basically like a live mailbag where you get to ask questions in the chat to Dr. Cooper. The three of us are going to be on with all of you from all over the world. we're going to record that and publish it as our 100th episode. So we would love for you to take part in that, and we'll be giving you further details in episodes to come. So it's going to
So
be fun.
exciting.
Yeah.
I'm excited.
All right. Thanks, you two, for another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.